All right, hello everybody. So per usual, I'm gonna give it that awkward 30 to 60 seconds, sip my drink, and then I'll introduce what we're gonna talk about. All right, let's jump right in. So we're gonna talk about what a complete concussion recovery looks like. And I don't mean that like, yeah, of course, a complete concussion recovery means you don't have symptoms anymore and that you can do things. Like, absolutely, that's what a complete concussion recovery means. We're going to talk about how do you get there? Because on social media, in my clinical practice, I get people either commenting or direct messaging or literally showing up in my practice being like, I didn't get these steps. I didn't, no provider actually walked me through how I was supposed to recover. Most often people were told, hey, just wait a few more weeks. Just wait 2 to 4 more weeks until your symptoms go away. And that's just not helpful. It's really not helpful, as many people have experienced. So I'm not going to dive too deep into the weeds of like X, Y, and Z study said this, and this is the specific outcome of those studies. Though I will add 2 references when this gets uploaded as a video. I will add 2 references. They're the assessment and the management. So they're 2 separate papers, one on assessment, one on management for concussion and persistent concussion symptoms. And I can already see the first question here is, what if it's been 4 years? Every step we're about to go through is what you would look for acute concussion and post-concussion. We're at this point just going to expect different timescales. So an acute concussion, if you watch any of my other videos, if you watched any of my recent lives, we expect an acute concussion recovery to take 21 days. Now that still might be 21 days in post-concussion, depending on when you start the recovery. So it might be like 4 years and 21 days if you start at the 4-year mark. But sometimes it takes longer because now there might be a metabolic thing that we're looking at, or there might be a dysautonomia that we're looking at. So we're still going to turn over the same rocks that I'm going to talk about here in a second. So the treatment flow that I'm going to outline here that I use in my clinical practice is one that we see in the references that I'll post here later. So we see that treatment flow in the references, and then we also see this proposed by Complete Concussion Management. So CCMI, Dr. Cameron Marshall and his team have kind of pulled together the literature. And so we see it in the literature, we see it in CCMI, and it works. It's a really nice stepwise process to go through. Different clinics will do different variations on it, but what you'll see is all good concussion clinics go through these steps, maybe not in this exact order, but they hit all of these buckets. So what I'm going to go through is like 3 visits. What would 3 visits look like to cover everything you need? And it doesn't mean you're going to recover in those 3 visits. It just means that if you haven't received all of these things within at least 3 visits, you're missing a piece of your recovery, and hopefully you'll find what piece you're missing in here because you'll go, I never had that done. So the first thing that I'm going to do when someone walks in the first visit is we're going to try to make the diagnosis and rule out other things. And that sounds really silly. Like, of course, we're going to try and make the diagnosis, but it's actually missed or just kind of lazily diagnosed. It's just like, you fell down the stairs, or you got hit in the head. It was probably a concussion. And oftentimes it's like a pen light that gets flashed in your eyes and they go, yeah, it's a concussion. And that's just not proper. That's not what is recommended for a concussion diagnosis or for a concussion exam. So what is recommended is a full neurological exam, meaning you're testing cranial nerves, you're testing motor and sensory strength, you're testing reflexes, you're testing cerebellar function, and gait and posture. So gait is your ability to walk. We'll often do dual tasking. So I'll say, hey, I want you to walk up and down this hallway or up and down this strip of turf in my office. And I want you to say every other month of the year out loud. Or I want you to count backwards from 200 by 7. We're going to give you some dual tasks, some cognitive tasks to do while you're walking. And that's how we're going to tease out cortical function. And what we should see in a neurological exam is we might see some things are hard for you, but we shouldn't see overt neurological deficits, because if we find overt deficits, it doesn't mean you didn't have a concussion. It just means that deficit is not concussion, because concussion doesn't cause overt neurological deficits. It causes functional and transient deficits. So if you have something overt, it's an indication for imaging and that you might have something different than concussion, which is why we do the full exam and we don't just shine lights in your eyes and think, oh, this person got hit in the head and their pupils look funny, or they're sensitive to light. So let's just call it concussion. The other thing that we'll look at is if we're not sure after, mechanism of injury might be whiplash, or it might be, not concussion. We'll do what's called a vestibular oculomotor screening, so a VOMS exam, and we'll use that. It's a symptom provocation test. So we're looking at, can we provoke symptoms? And if we can provoke symptoms, it's a 50-50 chance that it was concussion. If we can't provoke symptoms, that's where it's really useful, because if we cannot provoke symptoms on a VOMS, there's a greater than 90% chance that it wasn't concussion. And so that's what that first visit is. It's really diagnosing and ruling out other conditions. If we have a mechanism of injury, if we have symptoms, which we'll screen for on a post-concussion symptom scale, a clinical profile screen, and a River-Mead post-concussion scale, one of these validated questionnaires to say you have enough symptoms, you had a mechanism of injury, your neurological exam is normal, even though you feel funny, and the VOMS provoked symptoms, you had a concussion. So there's this big process. It only takes like 15, 20 minutes to do, but there's a big process to say, hey, we're sure it's concussion. Now, Lisa had asked, what's an example of an overt neurological deficit? So an overt neurological deficit might be blanking on this right now, but you might have really, really hyperreflexive reflexes. And so then we might go into something like Hoffman-Tromner's, which is we're going to flick your finger, and we might see your thumb start to move in as we're flicking your finger, and that tells us what you might have an upper motor neuron lesion, so something above the lower motor neuron, so something above that lower motor neuron, something possibly cortical going on that we would want to then image. We might look at something like a Babinski. We might look at clonus. We might see that those are kind of upper motor neuron signs. We might see that we go to test muscle strength, and on this side you're really strong, and on this side you can't even hold. And so you've got overt weakness. So we want to make sure there's not a neck injury or nerve compression or something else going on there. So that's what we mean by overt. Functional is what we might see in the VOMS, where I have you do pursuits and we're looking side to side, and that you can do it, but your eyes are kind of choppy and it makes you nauseous. You shouldn't get nauseous looking at something back and forth, but if you do, it's a functional finding that we then build rehab around. So first visit, you should get all that physical exam. Second visit, and this is really important, and this is missed even at some of the big concussion clinics here in the Valley in Arizona, is exercise testing. So Buffalo concussion treadmill test is the standard, but there are different variations that you'll see in the literature. One you'll see is like the modified YMCA bike protocol. There's a Buffalo concussion bike test. There's different ways to do it, but essentially we're just going to look at, do you have normal exercise tolerance? And normal means that you can reach 80 to 85% of your heart rate max, so your estimated heart rate max, without increased headache, increased nausea, increased fogginess, increased dizziness, blurry vision, any concussion symptoms. You might feel tired, your legs might feel heavy, you might feel like, wow, that was hard, because 85% of your heart rate max is not light. And so you might feel physically tired because it's an exercise, it's a workout, but you shouldn't feel concussion symptoms going up there. So this is something that, like the question earlier, like what if I've had this for 4 years? Exercise testing is something that, especially if you haven't had it done in 4 years, you should have it done, because that is probably going to be the biggest needle mover to driving your recovery. If you have POTS, exercise is the treatment. This is kind of a side tangent because this isn't a talk about POTS, but one of the things we see is that POTS, you get prescribed compression socks, increased salt intake, elevate the bed. You might get prescribed like beta blockers or some dopamine agonists or different things pharmacologically. And really the evidence says that if you're going to use a drug for POTS, it's to help you tolerate exercise, not as the treatment itself. So the ultimate treatment in POTS is something like the Levine protocol or some intensive aerobic and resistance training to improve your autonomic tolerance. So that's that notes. First visit, we're diagnosing, we're ruling other things out. Second visit, we're getting your exercise tolerance testing done and prescribing sub-symptom aerobic exercise. It's one of the fastest ways to improve physical, mental, and emotional symptoms of concussion. So then that moves on to the third thing. So we talked about proper neurological exam. We talked about exercise testing. Now, the third thing is we're going to need to look closer at your eyes, your ears, and your neck. You can't have a concussion without also getting whiplash. So you need to have a further evaluation of your neck. You need to have a further evaluation of the eyes and the ears and how they all integrate. So what we're going to look at there is we might repeat the VOMs. We might do special cervical tests, cervical flexion rotation, smooth pursuit with neck torsion, walking with head turns. You could do video nystagmography to look at the vestibular function. And I did this because there's goggles that vestibular physical therapists or ENTs will throw on you. And so that's kind of the whole picture there. And a concussion clinic, like a proper concussion clinic, if you were at my office or any of my colleagues that I'm connected with on Instagram and we kind of share each other's stuff, you're going to get those things in your evaluation with them. And it won't be in one visit because that would exhaust you, but within 1 to 3 visits, you're going to have all of that. You're going to have a complete neurological exam. You're going to have specific concussion screening and testing like the VOMs, the PCSS, the clinical profile screen. You're going to have exercise or autonomic testing. And so if you have POTS, you might not even get on the bike. You're probably not going to get on the treadmill. You might just be doing an active standing test or a tilt table test. And then we're prescribing exercise off of that. And then we're getting into the cervical spine and all of that. So that's what the full arc of concussion recovery would look like. And so for me, if we're going to create a timeline here, it's first visit, we're diagnosing, we're ruling out other things. And in that first visit, I'm also talking to you about sleep. I'm talking to you about paced breathing. I'm talking to you about nutrition. Given your diet and what we've picked up in the history, I might talk to you about specific nutritional supplements that might be relevant to your case. And then I'm going to say, hey, let's follow up in 4 to 5 days, depending on when I see you. So it could even be 3 days. But let's follow up in the next 3 to 5 days, and we're going to get you on the treadmill, or we're going to get you on the bike. I have a bike in my office right now, and we're going to find your exercise tolerance. And so we come back, we get that exercise tolerance. I also do an orthostatic screening on everyone because I want to rule out POTS in case it's there. And then I say, okay, awesome. You're going to exercise like this. You're going to keep eating. We're going to keep working on sleep hygiene. We're going to do all that. And I want you to come back in a week. So at this point, we're by week 2 or week 3, and we're going to look further at the neck. So I throw you on the force plate. We get your modified clinical test of sensory integration and balance. So where is your is it your proprioception? Is it your visual system, your vestibular system that's kind of throwing off your spatial awareness the most? We compare that to your VOMs, to your walking with head turns, to your dual tasking, to all this other stuff. And we build you sort of the physical, visual, vestibular, proprioceptive rehab there. And then usually by the 4th visit, the 4th week, is when we're kind of just clearing you. We're saying, hey, you have normal exercise tolerance. The VOMs doesn't provoke your symptoms anymore. You don't actually have high symptoms on the post-concussion symptom scale or the clinical profile screen. And then where we might go for a 5th visit, or where we might even go for a 6th visit, is if you're a contact athlete and we need to do an exertion protocol before we let you go back to full contact. So first visit, diagnose lifestyle things. 2nd visit, exercise testing. 3rd visit, visual, vestibular, cervical spine testing and rehab. 4th visit, we're either clearing you, we're fine-tuning things, or if you're an athlete, we're talking about either trying or preparing for that exertion protocol that will then do to clear you for full contact sports. I had a couple notes here. I'm always going off these notes over here just to make sure I talk about everything. A lot of people will ask me about labs. Which labs should I get for concussion recovery or post-concussion recovery? So in acute concussion, I often don't run labs. For the most part, if we can get your sleep hygiene in check, if we can get your nutrition in check, and we can get your exercise tolerance back up, that's going to take care of 95% of the recovery, and the rest is going to be this visual, vestibular, cervical spine piece. In post-concussion is where I run most of my labs. And what we're looking for there is we're looking for markers of inflammation, nutritional status, and then other overt disorders. And so the note that I wanted to bring up here is when I say overt disorders, I mean like Hashimoto's hypothyroidism, or an iron deficiency anemia, or diabetes, insulin resistance, blood sugar dysregulation. The thing you got to remember is that you're a person. And that sounds really silly, but like you're a person, and just because concussion happened doesn't mean concussion is the only thing contributing to your current health status. concussion often highlights what was there before, what was underneath. And so if you have hypothyroidism, it's going to impact your recovery. If you have insulin resistance, it's going to impact the fuel levels to your brain and the consistency of that, and that's going to impact your recovery. If you have iron deficiency anemia, it's going to impact your recovery. And I use those three examples because those are three very common things that I find in post-concussion patients, because they're very common in the world. And so it's not that you're a post-concussion patient that you have these things, it's that you're just a person, and your risk for those things based on lifestyle and different genetics and whatever makes you likely to have those things, and you happen to have a concussion on top of it. So we run those labs in the post-concussion case because there's this metabolic hormonal bucket that often, again, we don't even look that much at it. Here's a diet, here's some supplements, let's see how that goes over the next 21 days, and most people recover. We run the labs in post-concussion cases. And then nutrition, kind of already touched on. It's relevant in all cases, but again, particularly post-concussion. And I will say in acute concussion, it becomes a little bit more relevant in folks who are older than 18. So I find that like our 13 to 15 to 16-year-old athletes, they come in, they're concussed, we test their exercise, that recovers in like 10 days. We work on their neck a little bit, we do some visual vestibular training, and they're ready to go by like day 19. And I'm holding them back just because of the 21-day metabolism that we understand in concussion. That could be a whole separate talk, nutrition, supplementation, things like that. But just recapping the key things is, if you were to have a checklist of things that you want your neurologist, your primary care, your concussion specialist to do, you want a complete neurological exam, at least a VOMS for concussion-specific exams, a Buffalo concussion treadmill test or some sort of exercise testing, and then specialized cervical and vestibular testing for the neck and the ears. That could all be done in-house. And then if that's not, kind of working in rehab for over 2 to 4 weeks, that's when you might refer out. That's when I would refer out to ENT or to neurooptometry or some specialty work. But for the most part, all of that can be done in-house in a concussion clinic. That's what I do in my practice. So if you're working with me, we cover all that in the first 3 to 4 sessions. And that's what it should look like. So I'm going to look here. Yeah, so my son can walk 20 minutes fine around the neighborhood, but trying day 1 of the Levine protocol and recumbent bike brings on so many symptoms almost immediately. Yeah. So the Levine protocol is no joke. It's intense. And so what I'll sometimes do with my patients is we'll have a loading period, like a loading phase into the Levine protocol. So we'll find exercise tolerance or subsymptom threshold. One of the things, this could be, again, a whole separate talk. I'm going to cut the recording, so this is only people who are here live get to hear this. But so when we do the Buffalo concussion treadmill test, we put you on the treadmill and we have you walk at 3.3 miles per hour. And after 3 minutes, we increase the incline 1%. Every minute until 15%. And if you're still going and you still haven't had symptoms, then we increase the speed. But the problem with that is we're relying on symptoms. So we're saying, hey, tell me when you start to feel like crap. And it's pretty barbaric. So tell me when you start to feel like crap. Right here. Okay. And we pin that heart rate where you start to feel bad. But what other research is showing us is that if we're measuring ventilation rates, or we're measuring gas exchange, or we're measuring your actual blood flow, like when I say this, we're putting a stethoscope up here and we're actually listening to your blood flow as you're exercising, we find that before symptoms appear, you'll have a Turk murmur, a transient exertion-related carotid murmur. It's a totally normal thing. It just happens way earlier in concussed patients. And so you'll start to restrict blood flow and kind of shunt blood away from the brain too early in concussion. And then the other thing we'll see is that your carbon dioxide breakpoint, so this kind of ventilatory threshold where you'll start to breathe off more CO2 than you're producing, and you'll see CO2 levels start to dip when you're measuring gas exchange. We see that happens way earlier in concussion patients too. So you end up breathing harder, faster. You start to vasoconstrict when you lose all that CO2, and that all happens before you even have symptoms. So with someone with POTS, we might find that the orthostatic table testing, orthostatic testing or the tilt table testing is more useful than an exercise test. And it's better to start low, go slow, and taper into the Levine protocol before we just say, hey, hit the gas, even though that's what a lot of people want to do. And then the other thing to throw in there is that your autonomics is not only neurocardio. The neuro piece of the cardio is a lot more deep than that. We've got to consider vestibular function. We got to consider what areas of the brain, this is from one of my mentors, Dr. Kaiser, but what functions or systems or areas of the brain are possibly overworking that are contributing to your autonomic function, or underworking that are contributing to your autonomic function, causing you to fatigue out and burn out earlier than should be normal. So again, you're on the recumbent bike and you blow out because you're trying to hit that maximal steady state or that base training state that the Levine protocol has, and you just can't tolerate it. Well, yeah, because your ventilatory threshold's off, your blood pressure, like your baroreceptor management stuff is off. And so maybe your vestibular system is contributing to that. Maybe your frontal regulation of autonomics is contributing to that. Maybe hormones and nutrition and all this other stuff is kind of contributing to that. So, and then again, here, there was a note with small fiber neuropathy. So again, that sympathetic innervation in the lower legs, not being able to squeeze and constrict and prevent blood from pooling and allowing it to come back up to the heart. It all plays a role. So long-winded kind of note on that is I will taper my patients in. So it might take longer. The Levine protocol is classically 3 months. We might be working for 6 months, 8 months, however long it takes, but we're meeting the patient where they're at in terms of exercise tolerance, while working on these other pieces that feed into that autonomic system. So I'm going to leave it there. Thank you guys for joining. I'm going to cut that last part off. That was just special for you guys. But yeah, so I will be posting, I think next week we'll be talking about dizziness, because that's the one that I missed last week. So we'll be talking about dizziness, what it means, and all that fun stuff in the context of concussion. So I appreciate you guys. Thank you. Have a great weekend.